Good afternoon, everybody. Welcome. This is an exciting afternoon. We're delighted to have our guest today, Dr. Danielle Scholze, who's here as a faculty candidate for the Division of Neurodevelopmental Behavioral Pediatrics. Dr. Scholze is a native Wisconsin. Okay, somebody help me. Wisconsinite. Okay, I am not a native Wisconsinite. And she did her undergraduate work at UW La Crosse, and then attended UW Madison Medical School and was here, and then went on to Rainbow Babies and Children's in Cleveland to do her residency, and is now completing she is in her last year of fellowship at UC Davis Mind Institute in Developmental and Behavioral Pediatrics. And I know that she is being honest about her Wisconsin roots because we had a lovely conversation about cheese curds last night. But seriously, Dr. Scholze brings a lot of experience already at this early stage in her career, and is going to be telling us today about her work with Fragile X.
Thank you. So first of all, I just wanted to say thank you, everybody, for coming, and it's really nice to see so many familiar faces. I feel between the last visit and this visit, I've met so many of you, so I really appreciate you guys being here and learning a little bit about Fragile X with me. So I'm going to talk today about targeted treatments in Fragile X, and then some of the expansion of targeted treatments into other disorders as well. So basically, I'm going to start off with some background information about Fragile X, the syndrome itself, and some of the genetics behind it. Then I'll move into targeted treatments in Fragile X. And then I'm going to talk a little bit more about sertraline. Sertraline is a medication that I actually do research on right now. So I'm going to focus on that towards the end, and then just a little bit about kind of where do we go from here, and how will this help us in the future. So to start off with background, I think a lot of the people in this room hopefully know a significant amount about Fragile X, but I'm going to kind of start from the basics and just go over some of the overall things that we see in Fragile X, as well as the genetics. So Fragile X is one of the most common genetic causes of intellectual disability, and it's the most common inherited cause of intellectual disability. It's associated with a large kind of array of physical and behavioral characteristics, as well as a lot of associated comorbidities. And it has an extremely diverse phenotype. So I think a lot of people have traditionally thought about Fragile X as being in males who have a lot of autistic behavior, ADHD, significant cognitive disabilities. But when you actually look at the broad range of Fragile X, there's a lot of variation in that phenotype. And we actually see males who are mildly affected. We see people, women can actually have some effects as well. So it's a lot broader than what was traditionally thought many years ago when it was first recognized. And so today, the first part of this, when I'm going to talk about Fragile X as a whole, it's actually focusing more on that male traditional Fragile X phenotype that people have traditionally talked about. So Fragile X has a lot of physical features associated with it, and these two young men are kind of classic pictures of what a lot of these children and eventually adults will have. So they tend to have elongated, kind of narrow faces and quite prominent jaws. The ears tend to be large and kind of prominent, oftentimes cupped. They can have high arched palates when you look in their mouth, and that's important in speech and feeding. Strabismus is quite common. And strabismus, for those of you who don't know what it means, is basically when the eyes don't line up properly, and so one eye moves kind of differently from the other. And the reason that it's really important to know about that is these kids, if you don't catch strabismus and treat it properly, it can cause visual impairment. So it's really important to be kind of cognizant of that. Hypotonia is another very common thing that we see from infancy. So very frequently, these are babies who are real floppy and are very high tone. In older children, we very frequently see that hypotonia can be manifested around the mouth. So they're often kind of have droopy mouths, their corners of their mouths will turn down, and that can actually cause some difficulty in speech and articulation. So it's important to keep that in mind. In addition to hypotonia, we very frequently see very loose connective tissue, and so their joints are quite loose. And that tends to be manifested in hyperextensible fingers. So when you bend their fingers back, they bend back further than an average person, as well as double jointed thumbs. And flat feet is extremely common. Scoliosis is common, so curvature of the spine. And then the last part, the enlarged testicles, is very characteristics of Fragile X, and that typically develops around the age of 10 years, and they actually get larger over time until adulthood. When we look at some of the common behavioral characteristics of Fragile X, poor eye contact is extremely common. About 90% of the males with Fragile X will have poor eye contact, and that's in the context of autism or without autism. So you have to keep in mind these kids have difficulty typically with eye contact, even if they don't have autism. So tactile defensiveness occurs in about 80% of kids. So what we see is they are really sensitive to touch, so frequently tags in their clothes, seams in their clothes, socks. The seams in socks can be a huge problem. So it's important to keep those in mind when you see kids that have behavioral difficulties. Hand flapping occurs also in about 80% of kids, and again, like the poor eye contact, it is really common in kids who don't have autism as well as kids with autism, so you need to keep that in mind as well. Hand biting occurs in about 60% of patients with Fragile X, and very frequently they'll develop pretty significant calluses on their hands from that repetitive biting. Perseverative speech and behaviors are extremely common, again, in that same realm of those autism-like behaviors that we see, but it's not always in just the kids with autism. And finally, hyperresponsiveness to sensory input. So the tactile defensiveness is a part of that, but they can also be really overly sensitive to other senses, so loud noises, visual input, as well as actually vestibular. So these kids can actually be really sensitive to motion. So it's something to keep in mind. I've had patients who the parents tried to put them on a carousel and that motion was really agitating. So it can manifest in a lot of different ways. So you can have to think about all those different things when you're dealing with these patients. Some of the common associated conditions that we see, so intellectual disability and executive function deficits are pretty much almost universal in males with full mutations. So over 90% of those patients will have, most of the time, both, difficulties with both. Autism spectrum disorders are diagnosed in about 60% of patients with Fragile X. That being said, there is a lot of debate in the fact that a lot of people feel that it's being a lot of it is overdiagnosed. Very frequently, these kids are extremely social, are trying to engage and initiate, but because of some of those behaviors that I just talked about, they get diagnosed with autism because a lot of those inherent features of Fragile X also look like autism. So I think Fragile X is one of those disorders where you really have to look carefully at whether they have autism or not. So we usually recommend a pretty detailed evaluation when you're looking at autism in this population. ADHD is really common, so about 80% of kids will have full-blown ADHD or ADHD symptoms that cause difficulty, and anxiety as well. So I think a lot of people have seen a lot of these patients are very anxious. About 80% of kids will be anxious. A lot of times that's manifested in social situations, so they have a really hard time in areas where there's a lot of people. They have difficulty in new situations as well. And then finally, the mood lability. And I think this is one that has always, a lot of people think about because it's kind of very, it catches everybody's attention, but the self-injurious behavior, aggression towards others. And that's one of the really serious things that we see that can cause a lot of difficulties, especially for families. It's really distressful for the families to be dealing with that. When we look at the genetics of Fragile X, I'm going to try really not to bore you guys to death because a lot of this I'm going to talk about from here on out is a little bit technical. So I'm going to try to keep it as not boring as possible. But I promise you it will be important in the end because it's going to basically tell us why a lot of the targeted treatments we're using are important, and that's why we're utilizing them. So Fragile X is caused by a mutation on the FMR1 gene or the Fragile X mental retardation gene. And it's on the X chromosome, so the females have 2 X chromosomes and males have 1. And because of that fact, it's got an X-linked inheritance pattern. And so males tend to be more severely affected versus females because females have 2 of the X chromosomes. It's also, not only is it on the X chromosome, but it's also a CGG expansion. So basically there are these 3 bases in the gene, and in everybody, they're repeated a certain number of times. But in patients with Fragile X, it's repeated too many times. And when it's repeated above a certain number, so 200 is the full mutation, it actually causes that gene to be hypermethylated and the gene doesn't function anymore. So that particular gene is responsible for making FMRP, which is Fragile X mental retardation protein. And that particular protein is important for a lot of different reasons, which I'm going to talk about in a second. But when you have that expansion and that gene gets too big, it knocks out that, the ability of the cell to make that protein, and that is thought to be what results in a lot of the issues that we see in Fragile X. So this is the gene, and no, you don't have to memorize this, I promise. But what I wanted to focus on was this section right in the middle is that CGG repeat area. So normal, typical people, everybody has repeats. The average is about 6 to 44, and that's kind of the normal range. So most of the people in this room are probably in that range. Intermediate is kind of a gray zone. So the 45 to 54 repeats, we're not really sure a whole lot of what that means, but there's been a lot of look into what it actually means for patients and what does it really do. And then the last 2 are the categories that are really important in kind of the phenotypes that we see in Fragile X. So the premutation is between 55 and 200 repeats of that section, and that's typically seen Many years ago, people didn't think it meant anything. They said, oh, well, you're just a carrier and you can pass it on and it doesn't mean anything. Nowadays, we know premutation carriers and people with premutation can have a lot of other difficulties and problems, and it can lead to other issues, which I'll talk about in a second. The premutation then can actually expand out when it's passed from a mother to a child, and it actually gets bigger and becomes it can become a full mutation. And when it's over 200 of those repeats in a row, that's when you get that full-blown Fragile X, where it completely knocks out the protein synthesis. And so interestingly, if you're a premutation carrier, so if you're a woman who has the premutation, you can pass that premutation on, but it could also get bigger, and you could pass the full mutation on to your children. If you're a male, interestingly, the premutation doesn't get bigger. So males who have a premutation are not going to have a child with Fragile X for two reasons. One of them, they're going to pass that Y chromosome onto their son. So boys won't have anything, won't have any effects. But girls will not have the full mutation because the cells, the expansion actually isn't able to get bigger when you pass it from a male to a female. So it's one of the interesting things that makes the genetics and kind of that inheritance a little more complicated. So FMRP, this is the protein that we're going to spend a bit of time talking about, and this is the protein that's made by that gene. And it's a transport protein for messenger RNA, and really the take home is that it's really important in the regulation of translation of genes, especially genes that are important at the neuron synapse. So when you have those nerves coming together and they're supposed to be talking to each other, that FMRP regulates a lot of the genes and the proteins that are affecting that interaction. And so they're extremely important in neurological function and cognitive development. This is a diagram, again, I'm not going to have a test on this, but the reason that I like it is in that upper part, this is kind of the typical function. So these ribosomes are making protein, and they're making the right amount of protein because that FMRP is hanging out there and it's slowing it down. When you lose this FMRP, this protein is getting produced too much, and you end up with all these extra proteins in that synapse. And in the end, you get the synapse isn't functioning right because things aren't in correct balance, and you end up with kind of that cognitive and behavioral impairments that we see in Fragile X. So what does Fragile X mental retardation protein do? There are a million different things that people have found FMRP responsible for. These are actually just a few of them, and the reason I'm going to talk about these is that these particular aspects are going to be important when I talk about the treatments that we're going to look at. So FMRP upregulates MMP9, which is essentially an enzyme that's found in the synapse area in between the neurons. And it's really important in brain development overall, as well as kind of the structure of the synapse. And so it's increased, and there's too much of it in Fragile X. There's also upregulation of the mGluR5 pathway, and mGluR5 is essentially, it's a receptor in the synapse, and the purpose of it is to kind of calm or decrease the synapse and weaken the synapse, because you don't want synapses that aren't doing much to be strong. You want them to be kind of in the right balance. So it actually weakens synapses. Unfortunately, in Fragile X, this is increased a lot, so the synapses are weaker than they should be. There's downregulation of GABA receptors, and when you look at the brain, there's a balance of inhibition and excitation, and you want that kind of exciting and inhibition to be in a good balance. Unfortunately, in Fragile X, these GABA receptors that are responsible for inhibiting that kind of synapse the talking between the neurons, unfortunately, it's really downregulated. So actually, those neurons are super excitable, and so that can lead to a lot of difficulties because the nerves are firing when they really aren't supposed to be. And there's a lot of dysregulation in dopamine pathways as well, and dopamine is important for a lot of reasons. It's important for a lot of the reward systems, the pleasure center, memory, sleep, and so there's a ton of different things that are affected by dopamine, so it's really important. In Fragile X, it's really dysregulated. And then last, it increases oxidative stress on the neurons, and this oxidative stress essentially can result in early cell death, and so the neurons are dying off when you don't want them to be. Again, diagram, but I promise I have a reason for it. And so again, this is kind of similar to what I just talked about, but there's the FMRP that's down, so it causes a decrease in those GABA receptors, and those are the ones that are inhibitory or calm down the nerves. Up here is that mGluR5 receptor, and that's the one that's supposed to basically weaken those connections, and unfortunately it's really high, so it makes it even weaker. The NMDA and AMPA receptors at the top are actually, in addition to the stuff that I just talked about, are actually decreased. And those receptors are supposed to strengthen the synapses. So not only is the receptor that's supposed to make it kind of weaker really increase, you also have the ones that are supposed to strengthen it are down. So it makes for a really poor connection in those synapses. And so when you look at the premutation and the full mutation, I'm not going to talk a lot about that, but I did want to point out one thing from this slide. The premutation has an increase in that messenger RNA that I talked about. And that is important for one reason. That messenger RNA can actually be toxic, and it causes problems in the brain and other systems. And so when you have these premutation carriers, and like I said, they used to think that these people weren't affected, what they found is that it actually affects, it causes premature ovarian failure, it causes FXTAS, and FXTAS is Fragile X tremor ataxia syndrome, and it's essentially a syndrome that we see in pre-mutation carriers. We don't see it in full mutation, but it's because of the toxicity of that mRNA, and it actually causes the Parkinson's like disorder, and it can be really debilitating. And that actually is a large focus. We do a lot of research where I am on FXTAS and different treatments, and we see a lot of patients with FXTAS. In addition, patients with the premutation also have a lot of the same conditions that patients with full mutations will have. So they will oftentimes have some cognitive difficulties. They'll have frequently autism spectrum disorders, ADHD, anxiety, and a lot of that stuff that goes along, but typically not as much. And then they also have another group of symptoms. They have more depression. Migraines, autoimmune disorders, and hypertension are extremely common in these patients. And the hypertension has been a kind of a focus of a lot of research because the hypertension can actually cause earlier onset of FXTAS, they've been finding. And so there's a lot of kind of focus on making sure we manage the hypertension so these people don't develop this Parkinson's-like disorder at an early age. And then finally, the incidence is just up there. We're not going to go through the details, but it's really common. We see it a lot. And I think we're going to see it a lot more because of kind of the increase in genetic testing. The take home to this particular slide is I just really like it because it shows the percentage of kids that you'll see in full mutation versus premutation in males versus females. So as I kind of talked about earlier, the males are going to be more severely affected, the females are going to be less affected, and then the full mutation is going to be more affected, and the premutation is going to be less affected. The one place this is not the case is down at the bottom, depression. Interestingly, depression is flipped in the sexes, so males have less depression, females have more depression, and there's really not a difference between females who have that full mutation and males who have the full mutation, or and females who have the premutation. So it's interesting that that particular disorder is flipped, and I'm not sure exactly why that is, but it'd be something interesting to look into. FMRP is also important in a lot of other disorders, which is why I'm going to talk about some of these targeted treatments being used in other disorders. So in autism that's not associated with Fragile X, depression, bipolar disorder, all of these have actually been shown to have decreased FMRP levels in the brain. In a study that looked at schizophrenia, they actually found that the level of FMRP directly correlated with the age of onset of symptoms of their schizophrenia as well as IQ. And then we also know that seizures decrease FMRP and are also associated with kind of more severe autism symptoms in a lot of disorders, both idiopathic autism as well as NF, tuberous sclerosis, and Fragile X. So all these things kind of say, hey, Fragile X is more, or FMRP is more important in things other than Fragile X as well. So I'm going to move on to the targeted treatments, and I'm hoping that these will not make you all tired. They're exciting to me because it's kind of a really exciting time, and we have a lot of treatments that we didn't used to have. Unfortunately, a lot of them have failed, but we're trying and we're working on it, and so it's a really kind of fun and exciting time to be in Fragile X research. The big thing about targeted treatments is they're really just focused at a molecular mechanism that really causes the disorder. And so it's really important to look at animal models and stem cells. They've been kind of instrumental in development of these treatments because you can look at both kind of behavioral aspects in the animal models, but you can also look at the actual nerve function in the stem cells. And so you can see which of these compounds can be effective in both of those two places that you can't really do in humans. The other nice thing about it is you can test a lot of different compounds much quicker than you could ever test in humans. So you can look at thousands and thousands and thousands of potential targeted treatments and narrow it down to a couple that are looking the most promising, and then look at those in human subjects. And a lot of these treatments were actually developed for other disorders. So a lot of them, and I'll talk about that in a second, but they're developed for diabetes and antibiotics and all this other thing, but they've been found to have effects on these targets and mechanisms. So this is a diagram that I'm going to show a couple times, but don't memorize it. It is basically the synapse. So the middle blue area is the synapse in between the two neurons. The upper part is the presynaptic membrane, so the nerve that's sending a signal, and the bottom part is the postsynaptic membrane, and that's the nerve that's going to be receiving that signal. And the reason that this is up here is I just wanted to show these are all different areas that are actually targets for these treatments. And there's a ton of different targeted treatments that are actually have been researched and looked at, and we're looking at in humans as well. So this is a lot of this research is done at the Mind by Dr. Hagerman, who I work with, and all around the country. Liz Berry-Kravis does a lot of the work in Chicago. So there's a ton of research in all these different areas going on. The first compound I'm going to talk about is minocycline. So minocycline, a lot of you may have heard of minocycline. It's very frequently used as an antibiotic for acne. It's pretty widely used. It does have some side effects, but overall it's fairly safe. It's been pretty well studied. And what they found when they looked at minocycline, it actually decreased MMP9 levels, which is the one that I talked about that's important for kind of the structure of the synapses. And it also helped mature the synapses in cultured cells. In addition, when they looked at mouse models of Fragile X, the mice models were actually treated from birth for about a month, and it actually completely rescued all of the changes that they see in the nerves, but it also caused behavioral improvements in anxiety and kind of some of the behaviors that we see in the Fragile X mouse. So it kind of was seen to have some improvements in two different areas. And lastly, it's been shown to decrease apoptosis or cell death. So we talked about kind of that some of these are at an increased risk of cell death. Well, it helps improve that. So minocycline has been looked at in humans as well, and there was a randomized double-blind placebo-controlled trial of minocycline done several years ago, and it was in kids between the ages of about 3 to 16, and they did it for about 3 months. So they had the patients either on minocycline for 3 months or on a placebo for 3 months. And they saw no difference in side effects, no adverse reactions, so it was very safe. And they did find some significant improvements in CGI-I, which is, if you're not familiar with it, it's basically a scale that the clinician uses to rate how much improvement or lack of improvement there is. So it goes from, very much worse to very much improved, and all kind of that in between. And so you basically rate it as a clinician. They also used visual analog scales on that study, and the visual analog scales are essentially a line. This is the worst, this is the best. The parent puts a line where they feel their child is, and then they go back later and put another line. So you basically look at that change. And they saw differences in those visual analog scale changes in anxiety and mood-related behaviors as well. So there was definitely some improvements in that group. And we actually use minocycline in a lot of our patients as a targeted treatment, and we've seen a lot of patients who've had significant improvements when they were on it. So Metformin is another medication that's widely used. So we are going to go from acne medications to diabetes medications. So Metformin is a medication that is used for type 2 diabetes. It has really been very well studied in both adults and kids, so it's been very safe. And it has been really helpful for decreasing overeating as well as obesity in patients. In patients with Fragile X, we know that they're at an increased risk of being overweight in general. We also frequently put them on atypical antipsychotics that can cause them to gain weight, so that can cause another issue. And then finally, about 10% of patients with Fragile X syndrome actually have Prader-Willi phenotype, and those particular patients are very prone to obesity and a lot of overeating. And so because of those things, this medication has actually been prescribed in patients for those particular aspects of their Fragile X and health. In animal models, they've actually shown that there have been improvement in cognitive and behavioral deficits. So they actually have a fly model, a fruit fly model of Fragile X. Who would have thought? But they do. And when they use metformin in those the fly model, it actually improved their memory. In addition, they did mouse model studies, and they actually saw improvements in cognitive and behavioral aspects in the Fragile X mouse models. There was a couple different studies. So there's a lot of kind of promising data on that. There is a case report in press right now that was from our center, and it was in 7 patients with Fragile X that were treated with metformin. 6 of the 7 patients were older, so in teenager up to adulthood, and those 6 were also overweight or had the Prader-Willi phenotype. And when they treated those 6 with metformin to help with their metabolic abnormalities and their weight problems, they saw improvement in all of those aspects. So their labs got better and their weight improved, and they did better overall. But the more important thing is that all of those patients had significant improvements in their general kind of behavior. So it ranged from improvement in their social behaviors, improvement in irritability, and so it was kind of one of those things that people were like, what's going on here? Why are these patients getting a lot better? And there is some evidence that would explain that aspect. So the 7th patient was a little different from the first 6. It was actually a younger child, and I'm trying to remember the exact age. It might have been 4. And he was actually just treated because they had seen improvements in other people, and she just wanted to see what would happen. And she knew the family really well, and they wanted to try something different. And she tried it in that patient. And he also had massive improvements in his behavior, and he had no reason to be on the metformin other than the behavior. So based off of all of kind of that information, there is going to be a randomized controlled trial in patients with Fragile X that should be starting in the next couple weeks by us. So we're excited about that, and hopefully that will show some promising results. The next group of medications are some, or targeted treatments, are ones that I think are kind of a little bit newer. These have actually, the other 2 have been around a little bit longer, and I think mGluR5 antagonists are very exciting. So the mGluR5 antagonists act on the mGluR5 receptor, and that's the one that is kind of supposed to cause that long-term depression and keep the synapses kind of in balance. And in Fragile X, it's extremely upregulated. So there's way too much of it, and so it actually causes weakening of the synapses over time. So mGluR5 antagonists are actually thought to be a big part of, or mGluR5 in general is thought to be a big part of why Fragile X patients have intellectual disability. And it's kind of, I have already kind of explained this, but that lack of FMRP causes increase in these mGluR5 receptor activities. And in the end, that causes abnormalities in the ability of the neurons to function properly, and it causes long-term depression. So they're kind of, they're more likely to die off and not have good connections. In mouse models, they improve seizures and behaviors in the Fragile X mouse right away, and that actually was, the first study was looked at in mice that from birth, so they were treated from birth. The very exciting study that got everybody super pumped about mGluR5 antagonists is there was actually a study that looked at adult Fragile X mice. So these were mice that were pretty much fully grown and were already exhibiting phenotypes. Phenotypic behaviors that they had that they see typically with Fragile X, and they actually found that it corrected the phenotypic abnormalities in the Fragile X mice in cognitive, behavioral, pretty much everything that they saw in the Fragile X mouse was corrected and reversed, which was extremely exciting for everybody. But unfortunately, when they did studies in adults and teenagers, they didn't really see any improvement. So right now, there's actually some studies that are ongoing looking at mGluR5 antagonists in kids. So our hope is that by catching the kids with the more developing brains, we can do more good and improve their overall outcomes. The last 2 targeted treatments I'm going to talk about before I focus on sertraline is they both act on that GABA receptor, which is that inhibitory receptor that just isn't as active in patients with Fragile X. So the first one is our Baclofen. A lot of people in here have probably heard of patients on Baclofen, which is frequently used in CP. Our Baclofen is essentially just a very specific form of Baclofen that's more potent on specific areas, and I'm not going to go into details on that. And so it basically activates GABA receptors, so it increases that inhibition. And it has been shown in the animal models to kind of improve on that increased protein synthesis, and also can correct some of the abnormalities in the actual neurons that we see. And so there was a randomized double-blind placebo-controlled trial of Baclofen as well, and of course there were some disappointing parts. The adolescent and adult group didn't show any improvements, but the group of children with the highest dose actually did show some significant improvements in irritability and actually also parent stress, which is interesting, and had some trends that were improved in other areas, but none of the other ones were clinically significant. The bad part about it is that they did have significant adverse effects in those groups and had quite a few patients who actually discontinued. So they saw aggression, agitation, hyperactivity, some staring episodes, and anxiety in those patients. So that particular medication is still looked at a little bit, but not as much as it had been before, just because of the side effects and the combination of not quite seeing as many results as we'd like to see. Ganaxolone is another medication or another targeted treatment that acts on the GABA receptor. This one acts specifically on the GABA A receptor, and again, it just kind of increases it. Ganaxolone is basically a synthetic man-made version of a neurosteroid, and that neurosteroid allopregnanolone has actually been looked at in the FAX-TAZ patients, which I talked about with the premutation carriers, and they're doing a lot of studies on that in that population. This particular targeted treatment is actually looked at in a whole lot of different disorders. So they've looked at it in Angelman mouse models. They've looked at it in PTSD, actually, models in mice, which I've never heard of. I don't know how that happens, but it's pretty neat. As well as mouse models of autism, and then also seizures in mouse models. So this is kind of really kind of broad-acting targeted treatment that they're really using in a lot of different ways. There is a randomized double-blind crossover trial that we will be starting very soon in ganaxolone, and that'll be in Fragile X patients between 6 and 18, and we're really looking at anxiety, attention, and behavior issues, and that's funded by the Department of Defense. There are also ongoing studies looking at drug-resistant seizures as well as PTSD and ganaxolone, so it's kind of an interesting treatment. So from there, I'm going to focus on sertraline, which is what I do a little bit more research on. And sertraline is a medication that basically increases the amount of serotonin that's in that synapse area. And we know that serotonin is down in patients with Fragile X as well as autism. So this is the serotonin system, hooray in all its glory. And I'm not going to ask you details of that, but it is really important in regulating mood. A lot of people say it's like kind of the happy, transmitter. It's important for social behavior and anxiety. So it's got a lot of really important purposes, and a lot of the things that I'm describing are dysregulated in Fragile X. This study is based off of, was done actually off of some animal research. Initially, there was animal research that showed that patients, or that animals had abnormal serotonin production in the Fragile X mouse models and autism models. And so this study was actually done in children with autism and without autism. And what they looked at is they looked at the ability to synthesize serotonin using PET scans. And the interesting part about it is if you look, this line up here, the smaller blue line, are the patients that did not have autism. And this darker blue line are the patients that have autism. So if you look at that, you can see in that first very early part of life, the kids that don't have autism have this huge spike in serotonin, ability to make serotonin. But the patients that are not autistic have a really slow, gradual slope. So there's a huge difference in very early life between the patients with autism that are really low and the patients that do not have autism. So there's a huge gap in that serotonin production between those two groups. SSRIs are medications that are really frequently used in patients in general, and like I said, sertraline is one of these medications, and they increase the amount of serotonin in that synapse. But in addition to just increasing the serotonin in that area, they've also seen that it stimulates neurogenesis, so new nerve formation, and it actually also increases BDNF levels, and BDNF is brain-derived neurotrophic factor, and it's actually really important for nerve survival and maturation. And so in patients with Fragile X, it tends to be down, and these medications have a tendency of increasing. In addition, sertraline, which is the medication that I specifically look at, is the only SSRI that's been shown to have modulations on the dopamine system as well, which is also affected in Fragile X. So it's got a lot of importance in general. So sertraline is widely used to treat anxiety in children. And over time, people have very frequently noticed that patients with autism, patients with Fragile X, patients with difficulty in language frequently had improvements in their speech and language when they were on it. And so there are kind of thoughts that not only does it affect the neurobiology that I just showed, but it also decreases anxiety. So in a couple of ways, it seems to help these patients that become better able to communicate. There was a retrospective study of children with Fragile X that actually showed, they basically compared patients with Fragile X syndrome versus patients with, and they were either treated with sertraline or were not. And they looked back at those patients, and they found that the patients that were on sertraline for most of the time anxiety, actually their language scores improved significantly more than the patients who were not on sertraline for other reasons. So that prompted a additional study. So this is a randomized double-blind placebo-controlled trial of sertraline in young children with Fragile X, and that was completed at the Mind Institute a few years ago. They looked at, in the end, 57 patients were randomized, and they gave the patients low-dose sertraline, which was 2.5 milligrams or 5 milligrams, and that's a very, very tiny dose when you use sertraline in patients. And they followed them for 6 months, did testing before, testing after to see what would happen in the end. The primary outcome measures were the CGI-I, that one that looks like kind of like, are they improved, are they not improved? But also the Mullen scale's expressive language. And secondary outcomes were kind of the rest of the Mullen, as well as some sensory processing measures. There were some anxiety measures. There were a lot of measures, but and then visual analog scales. So I'm not going to talk about all the other measures because there's too many to go over. So when you looked at the Mullen scales, the primary outcomes of expressive language actually didn't show a significant improvement. So if you look down here, expressive didn't show significant improvement. But interestingly, when they looked at visual reception scores and fine motor scores, they actually saw a significant improvement in those, as well as the kind of combined cognitive score and the combined age equivalent. So if you look at all of these areas, this diagram essentially shows the difference between the beginning and the end in the patients with sertraline, taking away the placebo improvement. So they're basically looking at the difference between how much they improved from the beginning to the end when they did or didn't have sertraline. So we're trying to basically remove out that placebo effect and the natural progression, because obviously in 6 months kids are going to have some development. So they're pulling that out. And all of them actually were improved when you looked at the sertraline versus not. So that was very exciting. When they did actual post hoc analysis, they actually separated kids with Fragile X who had autism and who didn't. So in the initial study, it didn't matter whether they had autism, they just needed to have Fragile X. When they pulled out the patients who had Fragile X and autism, those kids actually did show a significant improvement in expressive language changes. And they also did look at some genetic correlations as well, and saw a few kind of mild correlations, but nothing really significant. So what did we learn? Patients did really well in this study. We didn't have a lot of it. We didn't have any severe kind of adverse outcomes. The side effects were no different whether they were on placebo or the medication. The parents were really happy with it. The primary outcome measure did not show significant improvement on the general population. However, in those patients with Fragile X and autism, it did show improvement. So that was kind of exciting. There were improvements on fine motor and visual spatial difficulties, and from a clinical perspective, the families were really happy at the end, and almost all the families said, I want to continue it, whether they were on it or not, because the families who were seeing improvements wanted to continue, and the families who didn't wanted to give it a try. So overall, it was pretty easy. We had very little study dropout, so it was kind of a really easy to do study, and it went very smoothly. So from Fragile X, it was actually kind of switched gears a little bit, and we went into idiopathic autism. So looking at kind of the results from the patients with Fragile X who had autism who had improvement, as well as a lot of the similarities between a lot of those abnormal pathways in Fragile X are also abnormal in idiopathic autism. So the synapse formation abnormalities, the difficulty in kind of that plasticity area of the synapses, abnormal balance of that excitation and inhibition, as well as the serotonin abnormalities. Those are all in both groups. So why not go into doing a similar trial in autism? So we are actually currently doing a randomized double-blind placebo-controlled trial in kids between the ages of 24 and 72 months who have autism, and they are basically in a screening visit. We do DSM-5 criteria, and then they also get an ADAS or an ADIR and make sure that they meet both of those in order to qualify for the study. The recruitment goal is 72 participants with the hope that 60 of them will complete it, and they're followed for 6 months just like the initial study with multiple visits. We have found that recruitment has been much harder than we thought. So with the Fragile X study, it was extremely, extremely easy to recruit the patients. And I think part of that is Dr. Hagerman that I worked with is very well known. Her patients love her, and they were really quick to jump in and say, yeah, I want to try this. The idiopathic autism has been a lot more difficult, and I think a lot of it comes down to a lot of the families who have kids with Fragile X are more aware because it's inherited. So a lot of them are already aware of what's going on, and so they have a better idea of kind of the long-term effects. When you have a family who's just diagnosed with, their child is just diagnosed with autism, it's very overwhelming. They don't know where they're going, they don't know what they're doing, and it's scary to say, yeah, I might give my kid a medication, and I don't really. So we've had a really hard time recruiting. A lot of the people we've recruited actually have been physicians. So we've had a lot of physician recruitment who were interested in trying it, but we've had some community recruitment as well. So we are actually currently on an extension to recruit for a few extra months because we're theoretically supposed to be done in a couple months, but we're going to continue to recruit a little longer. So I already went over that. And our primary measures are also going to be the Mullen, but we're going to look at all of the Mullen, and as well as the CGI-I. And there are a whole lot of other measures that they're looking at. They're going to do visual, we're doing visual analog scales. We're also looking at anxiety, and I'm particularly interested in that preschool anxiety to see if there's any correlation between who improves and who doesn't versus their anxiety scores. So that's kind of the area of this study that I'm more interested in. And so how are things going right now? The medication is really well tolerated. We're having really no side effects. The patients are, for the most part, following through. We had one patient move out of the country and another that we lost to follow-up, but otherwise everyone's been following through. A lot of the parents are seeing improvements. I think the interesting thing is, unfortunately, the primary outcome measures in the Fragile X study didn't show a lot of improvement. And I think after working with a lot of these families, what they describe is not that their kids went from not speaking to speaking. What they describe is that their kids had some words, but they're using them more functionally and more often, and they're also using some of the gestures more functionally and more appropriately more often. So I think it's hard to pick that up on a lot of these studies, but the parents are seeing improvements. You just don't see it in the testing because of, I feel like, the particular quality of the improvement that parents are seeing. But like I said, it's been really difficult to recruit patients. So where do we go from here? Because there's a lot of stuff going on. Obviously, a lot more clinical trials are needed. None of these medications were the be-all, fix-all of everything, but there's definitely some promise there, and I think we have a lot more work to do. I think we need to focus on younger children. So what we've learned is a lot of the older children, adolescents, and adults don't have a lot of improvement, but I think if we can find and study the younger children, I think we're going to have probably a lot more benefit found. The other thing that previously had been lacking is most of these trials are strictly medication. But if you think about it, if your goal with these medications is to make the connections better in the brain, it makes sense to say, well, let's put it with a really strong intervention, intensive interventions and therapies, and really make the most of that improved connectivity. And so I think a lot of the newer trials are actually combining both the medications with intensive therapy. And the great part about that is not only does it allow for more improvement in the trial, but it also gives all of the families some extensive therapy and intervention that they may not get otherwise. So I feel like there's a really nice benefit to that, and that both groups, whether they're on the medication or not, will get those therapies, and I think it's really nice. So we're doing some intensive language interventions that are actually Skype based, and we're also doing some other kind of behavioral interventions that are associated with it. So that's exciting as well. And obviously translating it into clinical practice is important. So we can do all this research, but if we can't get it out to patients, it's not going to help many people. So that being said, I just wanted to say thanks again for coming and listening to me talk. I obviously have to say a massive thanks to Rondi Hagerman, who is probably the most amazing mentor a person could ever ask for. And my entire kind of developmental behavioral department, my scholastic oversight committee, and all my other fellows that I work with. And it has been really fun and a great time in my fellowship, and I'm looking forward to finishing up the next year. And at that point, I will take some questions. Most of the, like for the sertraline studies, we're actually collecting blood samples. So we've been collecting blood samples, and some of those are being used for inflammatory markers, and they're also being used to look at some of the genetic markers. These studies aren't looking at any other collection, although a lot of the other Fragile X studies that we have running do skin biopsies. Any other questions? Yeah?
Are most of the current sertraline trials still using very low dose?
Yes. Yeah, they're still usually about 2.5 or 5. Mm-hmm. Yeah. Which is another kind of thing that we've been thinking about is we're using such a tiny dose. Maybe if we can increase it, we may have more. The most common side effect of it is actually hyperarousal, so these kids get kind of overexcited. And that's really hardly ever seen in the doses we're using. So if we could increase it, we may have more of that, but we may also have more benefit. Yeah.
In your intensive treatment considerations, are alternative communication maybe considered as one?
I completely agree with you on that. So as I was saying, a lot of the improvements that we're seeing in patients are kind of this qualitative. And the patients who don't have verbal language, I think looking at augmentative communication in these cases would be really fantastic because they really aren't using any tests that take that into consideration. So I think that's fantastic. Anyone else? I'll be up here too if you guys want to ask me any questions. So thank you again.